Hello, my name is Kieran Diol and I'm an Intensive Care Fellow at John Hunter Hospital. We're going to be talking about imaging of the spine for intensive care. We're going to be discussing several modalities, including X-ray, CT with and without contrast, and MRI with and without contrast. We'll consider why we image in intensive care. Trauma obviously forms a large part of our imaging load as part of the initial surveys and for follow-up of surgery and stability, but we also consider imaging in bleeding, threatened cord. Anesthetic instrumentation might have been a cause, or trauma or bone pathology, infections, epidural abscess, discitis, inflammatory diseases of the spinal cord. So with respect to trauma, the big question is when to image, and it's important for the exam that you're familiar with evidence-based decision-making rules. The National Emergency X-ray utilisation study assessed the sensitivity, specificity and negative predictive value of clinically significant cervical spine injury and reported it as 99.6%, 12.9%, so quite low, and 99.9% respectively. The Canadian C-spine rule was reported as 100% sensitivity and 42.5% specific to clinically important injury, and they didn't report a negative predictive value. So it doesn't matter particularly which one you use. There are controversies associated with each, but it's important to understand both of them, pick one and use it consistently. So the Nexus criteria: cervical spine injury cannot be excluded if one of the following is present. Midline cervical tenderness as elicited on palpation of the posterior cervical midline from the nuchal ridge to the prominence of the first thoracic vertebra, or if pain is reported on palpation of any cervical spinous process. Altered mental status, GCS less than 14, disorientation to time, place, person or events, inability to remember 3 objects at 5 minutes, delayed or inappropriate response to external stimuli, any patient or examiner reported neurologic deficit, recent history reported by the patient or an observer of intoxication or ingestion of an intoxicant. So physical examination such as odour of alcohol, slurred speech, ataxia, cerebellar findings, as well as behaviour consistent with intoxication, and the presence of a painful, distracting injury, bearing in mind that analgesia may have been administered. The Canadian C-spine rule focuses on slightly different elements, including the mechanism of the accident and whether a safe range of motion assessment. So a patient that you suspect may have a C-spine injury comes to your emergency department. Well, the question is, what modality of imaging are you going to choose? X-ray versus non-contrast CT. There are pros and cons of each, and a lot of controversy surrounded by what should be standard. The ATLS guidelines still suggest the 5 standard X-ray views, which are lateral, AP, Odontoid peg or open mouth view, right and left oblique views, or the swimmer's view. But in the context of trauma, these images can be really difficult to acquire. The patient may be in pain, they might be confused or unconscious. You can't get them to cooperate because of their immobilization devices or other injuries to get into the required positions. So other organisations such as EAST, for example, are suggesting that CT should be standard, in which case you'd be doing sagittal, axial and coronal with reconstructions, multi-slice, fine cuts. So when you've done your imaging, what are you going to look for? The mechanism is really important. Mechanisms can include motor vehicle collisions, falls, sporting, recreational injuries and assaults. And based on that mechanism and whether you think there's been a hyperflexion, hyperextension, axial loading or rotational force, you'll be guided to look at different types of injury at different spinal levels. Obviously, the higher the velocity or greater the force, the greater the risk of injury, but it's important not to forget low velocity injuries, such as falls from a low height or low-speed rear-end traffic collisions, particularly in elderly patients or patients where cervical bony pathology is already present, such as spondylosis. So potential injuries that we're going to be looking for would include vertebral body fracture, disc extrusion, cord contusion or compression, ligamentous rupture, epidural hematoma, facet displacement, and also vertebral or carotid artery injury. So if we're not going to miss any of these, we need to have a systematic approach. So here's a systematic approach for examining the normal lateral, and obviously looking at an X-ray or a CT, your approach is going to be quite similar. So firstly, we'd start with coverage, and it's important that all vertebrae are visible from the skull base to the top of T2. If T1 isn't visible, then you'll need to repeat an image with the patient's shoulders lowered, or you might need to do the look at the swimmer's view. Alignment. We'll check the anterior line, the line of the anterior longitudinal ligament, the posterior line, the line of the posterior longitudinal ligament, and the spinolaminar line, which is the line formed by the anterior edge of the spinous processes and extends from the inner edge of the skull. You won't see the spinal cord on an X-ray. It lies between the posterior and spinolaminar lines. Next, we'll look at the bone. You're going to trace the cortical outline of all the bones, looking for fractures, and we'll pay particular attention to the C2 bone ring. At the axis, the lateral masses, when they're viewed from side on, form a ring of corticated bone, and that ring isn't complete in all patients. It could appear as a double ring, but a fracture will look like a little step in that ring outline, so do look at it carefully. The vertebral bodies are spaced apart by the intervertebral discs. You can't directly see the discs on X-ray. These spaces should be approximately equal in height in the C-spine. Then you're going to look at the prevertebral soft tissue, which is quite important. Some fractures can cause widening of the prevertebral soft tissue due to hematoma. It can be quite a subtle sign. And so essentially the prevertebral soft tissue should be narrowed down to C4, less than 1/3 of the vertebral body width, and wider below, less than 1 vertebral body width wide. Finally, focus on the other structures in the X-ray. You've got some facial bones there, and also look for instrumentation, given that we're intensivists and patients might be intubated or have other lines. Have a look at this normal lateral C-spine X-ray and see if you can follow that systematic approach. For the AP, again, coverage, the AP view should cover the whole C-spine and the upper thoracic spine. Alignment, the lateral edges of the C-spine should be aligned. Have a look at all of the bones as we did systematically, circling each bone. Don't forget the odontoid process. Spacing, the spinous processes should all be visible in a straight line and spaced approximately evenly. Again, have a look at the normal AP X-ray and see if you can follow the systematic approach. So on the odontoid peg or open mouth view, what you're looking for is alignment of the lateral processes of C1 and C2. There should be a symmetry there, with the distance between the peg and the lateral masses of C1 being equal on each side. So the swimmer's view is an oblique view with the humeral heads projected away from the C-spine. Coverage here should show the C7 above the clavicle and T1 below, so you're really looking at that junction if you haven't been able to see it properly on the lateral films. Alignment, you want to match the corners of each adjacent vertebral body anteriorly and posteriorly. Now that we've had a look at normal examples of all of the different views of the X-ray or CT, we can consider abnormal imaging and what the indicators of instability might be. So if more than one vertebral column is involved, or there's an increased or reduced disc space height, or an increased interspinous distance, facet joint widening, or vertebral compression greater than 25%, these are all indicators of instability. So on the normal lateral X-ray of the C-spine, have a look at what the three columns are. I'd like you to trace the anterior column, which consists of the anterior half of the vertebral bodies and soft tissues, the middle column, which consists of the posterior half of the vertebral bodies and soft tissues, and the posterior column, which is all of the remainder, the posterior elements and soft tissues. So now we'll move on to looking at some pathology. For the X-rays and CTs, we're going to now be focusing on trauma pathology, and we'll go by mechanism. So first, considering axial loading. This is an example of a C1 fracture, a Jefferson fracture. Obviously, you'll have all sorts of different views. I'm just showing you some of the best views that you can look at each type of fracture from. So the C1 Jefferson fracture here is shown in the open mouth or odontoid view. Have a look here, you'll see that the space between the odontoid peg of C2 and the lateral masses of C1 is widened on both sides, and the lateral masses of C1 are both laterally displaced. They don't align with the lateral masses of C2 anymore. We've lost some of that symmetry. The Jefferson fracture is often caused by an impact or load on the back of the head, and it's often associated with diving into shallow water or impact against the roof of a vehicle and certain falls. In children, you might see it because they've fallen off playground equipment. In some instances, there's a hyperextension component as well. It consists of a fracture of the anterior and posterior arches of the C1 vertebra, and damage to the arteries of the neck can result in lateral medullary syndrome, Horner syndrome and ataxia, and the ability to sense pain or temperature. On the axial CT image, you can get a clearer understanding here of the fractures of the anterior and posterior ring of C1. Now we'll have a look at hyperflexion injuries, in particular the DENS fracture. So flexion loading is the most common cause of DENS injury in patients and results in anterior displacement of the DENS. If there was extension loading, i.e. a forward fall onto the forehead, which is quite uncommon, you result in posterior displacement of the DENS. So on this lateral X-ray, this is an example of a flexion injury, and you see anterior displacement of the DENS, loss of the smooth anterior line and widening of distance between the C1 posterior tubercle and spinous processes of C2. Note also that the patient's intubated and has an orogastric line in situ. So if we have a look at the coronal CT section, you can really see that the DENS has been fractured at its base, and we've lost the symmetry between the C1 and C2 lateral masses. They are no longer aligned. So an example of a hyperextension injury, the less common injury, is the C2 fracture, the hangman's fracture. So this is a high force hyperextension injury. An example might be a passenger hitting the windscreen of the car with the forehead with no airbags. The fracture involves the pedicle, the pars interarticularis of C2. You can see that it's snapped away from the DENS and the body here. So because this is a hyperextension injury, there's anterior displacement of the peg, and there's also anterior displacement of the body of C2. So this is an example of a fracture where it's very unstable because you're involving all three columns. So another example of a hyperextension injury is the extension teardrop fracture. It occurs when the anterior longitudinal ligament pulls a bony fragment away from the inferior aspect of the vertebra after a sudden hyperextension. It's quite common in diving accidents. So you can see here that little chip that's been pulled away from C2, but also note that there's widening of the space between the C1 and C2 spinous processes. It's associated with central cord syndrome due to buckling of the ligamentum flavum into the spinal canal during the hyperextension. Stable in flexion but highly unstable in extension. So even though it looks like a small injury on the X-ray, it's actually a significant pathology. So here are some interesting images. We're going back to a hyperflexion injury now, but with a rotational component. If you look here at the lateral films, you can see that following the anterior line down at the level of C4 and C5, you can see that there's gross disruption. Similarly, if we follow the posterior line, you can see that there's something amiss at those levels. So the hyperflexion injury has occurred at C4, C5 here, with widening of the interspinous space at this point as well. There's subluxation of about 25% with an anteroposition of 25% of the AP diameter of the vertebral body. If you look at the distance between the C4, C5 spinous process, it's widened, and you can see also that the C4 and C5 spinous processes appear shorter in the lateral view than their mates. This is because of rotation at this point. If you come to the AP view, on first gross inspection it doesn't look so terrible, but if we're following our systematic approach and we come to look for each spinous process, we can't see some of them and we realise that they're actually grossly malaligned. They're sticking out to the right side of the patient, which is the direction in which the rotation has occurred. Another example of a flexion rotation injury is the flexion teardrop fracture, different to the extension teardrop fracture. So this particular example is of a diving injury, and there's been an axial loading component here as well. So it's resulted in a fracture of the body of C5 with a small fragment being displaced anteriorly. There's a fracture of the spinous processes of C4 as well, and there's acute angulation at the level of C5, C6, with displacement of C5 in a posterior direction. We're going to look at an MRI of this type of injury later, and you'll see just how much pathology is evident. If we consider the CT images of the same injury, the vertical orientation of the fractures of the bodies of C4 and C5 indicate that there was severe axial loading. You can see those cracks straight down the middle on the axial and coronal sections. These vertebral bodies have exploded with a propulsion of bone fragments anteriorly. Those are the teardrops, and the larger part posteriorly against the spinal cord. Now that we've covered the C-spine and the major injuries that can occur, we can move to the thoracic and lumbar spine, and we can consider what our systematic approach here will be. We're going to be looking for lateral and AP views of these sections of the spine. The whole spine needs to be visible on both views. Alignment will be following the corners of the vertebral bodies from one level to the next, ensuring that they are in line. The bones, again, we're going to trace each outline of each bone, and they should gradually increase in size from top to bottom. The disc spaces gradually increase from superior to inferior, but due to magnification and spine curvature, the vertebral bodies and discs at the edges of the image can appear larger than those in the centre. The L5-S1 space is normally slightly narrower than L4-L5. Soft tissues, checking the paravertebral line, and also check whatever else is on the X-ray. Don't miss the pneumothorax, for example. So have a look at this image of a normal lateral thoracic lumbar X-ray and go through systematically as we've just discussed. So some of the pathology that we can see related to traumatic injury is compression. So here we have anterior compression. This is a one-column injury. So there's compression here of L4. Anterior compression injury, it's a common fracture pattern and it results from traumatic hyperflexion with compression. It's considered stable, but the greater the loss of height anteriorly, the greater the risk of middle column involvement. The burst fracture is another example of a T and L spine type injury. It's a two-column injury. The burst results from high force vertical compression trauma. There's posterior displacement of vertebral body fragments into the spinal canal, and this can lead to a high risk of spinal cord or nerve root damage. There's a loss of height, and you also see that there is a disrupted anterior and middle column here looking at the L5 vertebral body. The axial CT images clearly show that there's extension of this fracture into the posterior part of the vertebral body, and you could easily see how there could be damage done to the spinal cord. The most unstable T and L fractures are the flexion-distraction injuries, the so-called chance fractures. These are horizontal fractures that go through all three columns. They're associated with a high force deceleration. For example, somebody hyperflexing over the lap section of a seat belt. They most commonly occur at the thoracolumbar junction. They're unstable, they carry a high risk of neurologic deficit, but also of significant abdominal organ injury. The fracture line can pass through the disc rather than the vertebral body, so keep a lookout for that. So now we can move on to consider the use of MRI of the spine in intensive care. MRI is for soft tissue imaging. It's not going to show bony pathology with the same resolution as a CT scan, for example. So in trauma, we're using it to look for discoligamentous injury. And you'd consider it particularly if there was degenerative disease of the spine present. You're also looking for tumours sometimes and abscesses in ICU, discitis, encephalomyelitis, aneurysms and venous malformations, hemorrhage, demyelinating diseases, multiple sclerosis, transverse myelitis, hypoxic injury to the spine, for example after AAA repair, anterior spinal artery syndrome, herniation or degeneration of discs of the spinal cord, and also for planning of surgery on the spine. Decompressions and nerve root or spinal fusion, they're patients that are sometimes seen in an HDU situation. Don't forget that there are risks associated with the MRI as with CT. The main risks relate to the contrast materials, which can cause nephrogenic systemic fibrosis. Contraindications, obviously, if there's metal fragments, which trauma patients, you often end up having a discussion about whether various bits of hardware are compatible with the MR. It's often really hard to transport patients, as you know, from ICU to the MRI because of equipment compatibilities, difficulties ventilating and monitoring the patients. So it's a test that's not done lightly in ICU. Again, we're going to need a systematic approach. We're going to look for alignment on the T2 sagittals. We're going to follow the posterior vertebral line, which is sometimes called the marginal line, and we're looking at normal lordosis as well of the spine. Ligamentous laxity might allow for anterolisthesis when we're considering the posterior marginal line. Vertebrae, the quality of the marrow signal is important, whether it's increased or decreased, because this is going to be highlighted in tumour, osteomyelitis, hemangiomas and fractures. Looking at the discs for herniation, you'll get a much better understanding of disc pathology on an MRI. At the cervicomedullary junction, you're also looking for Chiari malformations, cerebellar tonsils descending into the foramen magnum. Don't forget that that very top of the spinal cord and the base of the brain stem is also going to be visible on a lot of your images. The conus should be looked at. You're looking for thickness and it should terminate at L1, L2. The cauda, excluding compression, spinal stenosis and narrowing. And then you're going to look at the intervertebral foramina. Lateral slices on a T1 weighted scan will be most useful here, and you should have patent intervertebral foramen. There's a bright fat pad and a dark nerve root coursing through it. Loss of the white fat signal suggests impingement of that nerve root. So one of the most confusing aspects of MRI can be what tissue colour you're expecting on different weightings. So let's consider each type of tissue separately. Water and inflammation, edema, it's going to be dark on T1, it's going to be white on T2. Diffusion weighted image, it's going to be an intermediate colour. Flare, water dark, the pathology stays white. Fat and therefore normal bone marrow on T1 is white, on T2 it's intermediate. Diffusion weighted imaging, it's light grey, and on stir it's dark. So bone marrow with inflammatory pathology on the T1 weighted scan is going to be darker. So the bone is intermediate on all of the different types of imaging, and if you use gadolinium then you'll expect bright pathology. So tumour, for example, will be brighten if it's highly vascular, but you'll also have black suppressed fat. So let's have a look at some examples of MRI, and bear in mind that this talk does not have an exhaustive range of images of different things you're going to need to know for the exam. It's just designed to give you a comprehensive overview. So let's consider trauma, and remember the MRI is looking at soft tissue, so we're particularly using it to look at ligamentous disruption and cord injury. So here we've got the T1 image on the left and the T2 image on the right, because on the left the CSF is dark and on the right it's light. You can see that at C5, C6, if we're looking at the posterior line, there's significant disruption. There's a dislocation with 50% anterior position of C5 on C6, very unstable injury. If you look at the cord on the T1 weighted image, it's not all that dramatic. When you look at the T2 image, however, you see that the pathology, the water, is bright and it shows up brighter in the cord. If you're looking at the anterior line, you can see that that's also disrupted on both images. Again, there's some edema in front of C6 on the T2 image. And if we look at the T1 image, you can see that there is a significant soft tissue swelling anteriorly. Again, that same rule that the prevertebral soft tissue is more than 1 vertebra width wide at the C5-6 level. So another use for the MRI in trauma is in the so-called Sclerosis injuries, where you have perhaps a normal X-ray or limited pathology on a CT scan, but significant neurologic deficit. So here we have an example of a 44-year-old female who sustained a fall on ice and then fell again the following morning. After the second fall, she had complete loss of motor function and sensation, and her physical examination showed that there was a lower extremity paraparesis with some upper extremity weakness on the right. So initially they were thinking a central cord injury. Now, if you have a look at these the sagittal CT scan that's here, it's not all that remarkable. The anterior posterior lines are relatively intact, but when you look at the C7 vertebral body, you can see that there is a small fracture there posteriorly. The MRI, on the other hand, is grossly abnormal. So the MRI of the same patient is shown here, and you can see the T1 weighted image on the left and the T2 on the right. There's a widened interspinous space at C5 and C6. There's soft tissue swelling at this level posteriorly. There's a subtle narrowing of the disc space at the C5, C6 level. You can see that there is edema of the discs at these levels. There's a break in the posterior longitudinal ligament, and on the T2 scan you can see that there is a cord injury there at the C5, C6 level. MRI is useful for examining metastases in the spine. The image in the top right here is the T1 image, and you can see that the metastases are dark. That's abnormal marrow. On the left, you've got the STIR. You have normal bone marrow is dark, and the abnormal bone marrow is light. The bottom image is the gadolinium contrast image, and you see that the metastases appear to be bright. In demyelinating disease such as multiple sclerosis, the MRI images are a little bit more variable. You can see here on the left is the T2 image, and you can vaguely make out that there are some ill-defined lesions at the level of C2 and then possibly down at the level of C4, 5 and 6. The image in the middle is the STIR image, and those lesions become a little bit more defined. But this combination of relatively clear lesions and some foggy areas on the STIR is characteristic of multiple sclerosis. If you look at the axial images, the transverse images, they show the dorsal location in a typical triangular shape, which is apparently common in multiple sclerosis. On the sagittals here, we've got the T1 weighted image on the left, and then the contrast image T1 plus gadolinium on the right, and you can see that there's no enhancement of the lesions, which is different than what we had seen with the metastases. Active MS lesions in the spine may enhance, but it's not as common as apparently lesions in the brain. So it's important to think for the exam broadly about the types of pathologies you see in ICU and understand the imaging for those pathologies. So if we consider transverse myelitis, up to 40% actually have no findings on MRI, and in the remainder the appearance is variable and non-specific. There's a large variation in the lesion size, but they most commonly extend for 3 or 4 spinal segments and occupy greater than 2/3 of the cross-sectional area of the cord. Typical signal characteristics are, on the T1, it's iso-intense or hypo-intense. As you can see here, it's not particularly defined. On the T2 weighted images, you have a poorly delineated hyperintense signal. And so on this particular patient, you can see that that signal commences at around about C5, C6. And with contrast, there's a variable enhancement pattern. So this image here with contrast looks quite similar to the T1 image that we saw earlier. Okay, so let's consider spinal cord infarction now. These images were taken 30 hours after symptom onset. A is the T2 weighted sagittal and C the T2 weighted transverse section. And you can see that there's onset of a hyperintense lesion with edematous expansion in the central portion of the lumbar cord and the conus medullaris. Diffusion weighted MRI demonstrates strong hyperintensity on the sagittal B and transverse D images, and so this is suggestive of ischemia. So times when you would consider this, I mean, this is central infarction here, which is a bit unusual for following a AAA repair. That would be anterior spinal artery territory, so it's a slightly unusual point for there to be ischemia. So in summary, we've talked about X-ray, CT and MRI as tools in intensive care. X-ray and CT, their main role in ICU is in trauma, and you need to decide which modality is important. MRI, good for soft tissue structures, inflammation, know a little bit about the weightings. And finally, you need to be systematic in your approach in general, and that'll give you the best outcome when you're reporting these scans. So finally, good luck for your exam. Here are some online references that may help you. MR Protocols is a work in progress. The other two are quite useful, and there's also radiopedia.org, I think it is as well. Good luck.